So without wasting further time, the abstract that has been given to me for presentation in the next 5 minutes is the GOTEC study, the 2014 TPExtreme trial, in which it was a randomized phase 2 trial, a multi-center open label, in which the Cetuximab, docetaxel, and cisplatin combination therapy, that is the TPExtreme arm, was compared with the extreme arm, in which platinum 5-FU was and Cetuximab was given. So it as a first line treatment in recurrent metastatic head and neck cancer. Next slide, please. So the study background was, next slide. Now, we know that the extreme arm, the extreme regimen has been the standard of care since a long time. And it has provided a 10.1 months of median overall survival in metastatic recurrent head and neck cancer. There was a phase 2 study, the GOTEC 2015, that had shown a 14 months of median OS survival when taxane replaced 5-FU, and thus taxane combined with cisplatin and cetuximab had shown an increased efficacy. So this randomized trial was conducted to compare these two regimens in order to find out which is a better regimen for our patients of metastatic recurrent head and neck cancer. So the rationale behind was basically they have found out that taxanes and cetuximab have demonstrated a synergistic effects in preclinical studies. And the TPEx regimen, when we omit 5-FU and include docetaxel, obviously it has a shorter infusion time, and it has easier delivery. Patient does not have to stay in the hospital for longer than a day, and there are fewer contraindications. So next slide, please. So this was the design of the study. First line recurrent metastatic squamous cell head and neck cancer patients, total number of patients that were included were 541. Those patients who had ECOG performance status of either PS 0 or 1, who did not receive any prior systemic chemotherapy for their metastatic disease, or had completed more than 6 months of treatment prior to the enrollment in this trial. They were randomized into two arms. The first arm was the TPEx arm, in which cisplatin 75 milligram per meter square was given every 3 weekly in combination with docetaxel, 75 milligram per meter square 3 weekly. And cetuximab was given at a dose of 400 milligram per meter square in the first week, and then weekly at a dose of 250 milligram per meter square. Total 4 cycles of chemotherapy with mandatory GCSF after each cycle, followed by cetuximab maintenance at a dose of 500 milligram per meter square every 14 days. The extreme arm, we know the doses, cisplatin at a higher, slightly at a higher dose, 100 milligram per meter square every 3 weeks, with a 5-FU continuous infusion, 4 gram per meter square, given over 4 days every 3 weeks, and cetuximab at the same dose that was given in the TPEx arm. The maintenance cetuximab was given weekly at 250 milligram per meter square. The primary endpoint was overall survival, secondary endpoints being progression-free survival, overall response rate at 12 weeks, quality of life, and safety with compliance. So there were also exploratory endpoints in which the second-line treatments were also considered. What is the effect of second-line treatment in these two arms? Next slide. So baseline characteristics were well balanced between the arms. The median age was 60 years in both arms. Number of males and were almost similar. Former smokers, prior platinum treatment receiving, who had received these type of prior platinum agents, were also well balanced between the arms. The most common head and neck malignancy was the oropharynx, 45% in the TPEx arm and 36% in the extreme arm. Second slide, please. So this was the result. Next slide. The primary endpoint was overall survival. It failed to show any significant difference between the TPEx and the extreme arm. The TPEx arm had shown a median OS of 14.5 months, and it was 13.4 months at the extreme arm. Similarly, for progression-free survival, 6.2 months versus 6 months, the p-value was not significant. And so basically, it failed to show any significant difference between the two arms in terms of survival. Next slide. Also, the overall response rate were similar in the two arms, 57% versus 59%, p-value of 0.64. Next slide. The difference between the two arms was related to the side effects. So the grade 3 side effects, adverse effects in the TPEx arm was lower as compared to the extreme arm, 81% versus 93%. Although grade 3 side effects were quite high in terms of percentage, but the TPEx arm patients had a lower rate of grade 3 adverse effects. Next slide. So the most common adverse effects that the difference between the adverse effects profile was related to the hematological adverse effects and the electrolyte imbalances. Probably related to the hematological adverse effects, basically I feel is related to the mandatory use of GCSF in the TPEx arm, and extreme arm, they did not use GCSF routinely. Also, the dose of cisplatin was higher in extreme. It was 100 milligram per meter square as compared to 75. That also might have been the reason why electrolyte imbalances was more in the extreme. Next slide. So the difference, as I said, was related to the adverse effects. Also the compliance, because the patients had to stay in the hospital for 4 days in the extreme. The compliance of these patients who had received TPEx was better. Median number of patients, median number of cycles that were given to the TPEx arm was 4 cycles. It was already planned to receive 4 cycles, but in extreme arm, only 5 cycles was the median number of cycles that were able to be given. Though patients who had completed all the planned number of cycles in the TPEx arm was 72%, demonstrating more compliance, and the delay in the chemotherapy cycles was higher in the extreme arm. Next slide, please. The exploratory endpoints, recently they have published the exploratory endpoints also, and approximately 79% of the patients in the extreme arm and 85% of the patients in the TPEx arm had received the second-line treatment. And approximately 16% in the extreme arm and 17% in the TPEx arm received immunotherapy as a second-line regimen. Next slide. There was one more difference between the two arms when we talk about the overall survival. In these two arms, when a second-line treatment immunotherapy was given in the two arms, numerically the overall survival was slightly higher in the TPEx arm, 21.9 months in those patients who had received immunotherapy as a second-line treatment. Next slide. Quality of life, obviously, much better in the TPEx arm as compared to the extreme arm. Global health status score, physical functioning, role functioning was much better. These are the major two differences, I think, that was seen in the TPEx versus the extreme arm: the compliance and the quality of life. Next slide. So this large randomized study, the summarize, TPEx study compared TPExtreme compared the basic difference was docetaxel versus 5-FU, and followed by cetuximab maintenance for first-line recurrent metastatic squamous cell head and neck cancer. Compared with the extreme arm, the TPEx regimen offered simplified dosing and administration and required fewer cycles of chemotherapy, 4 versus 6. As the TPEx regimen does not contain 5-FU, it is suitable for patients with DPD deficiency. Treatment with TPEx was associated with robust overall survival, PFS, and overall response rate with low levels of progression. TPEx demonstrated improved safety and compliance versus extreme arms. TPEx demonstrated improved quality of life outcomes versus extreme, and with improvements in global health status. Treatment with first-line TPEx followed by second-line immune checkpoint inhibitors resulted in unprecedented long median OS of 21.9 months, and it should be considered as a standard of choice for good performance status patients who are not candidates for immunotherapy as on today for first-line metastatic